It's Dr. Cassie Smith, and welcome to Back to the Basics, a simple approach to health in the modern world. I appreciate you taking the time to join me today and hopefully learn ways that could help you improve your health. The modern world has left little time to focus on health and wellness. I hope to give you some quick and simple ways to be well and live your best life. Welcome back to this week's episode of Back to the Basics. I'm Dr. Cassie Smith. This week I have a special guest. His name is Dr. Marcus Smith. We are not related, although we get asked that a lot. He's not my husband, but he is a wonderful cardiologist in Oklahoma City that I send a lot of my patients to. And I asked Dr. Smith to come on this podcast today because I wanted to talk to him about something that's kind of near and dear to my heart and his as well, which is POTS. So postural orthostatic tachycardic syndrome. So we're going to dive into why we think that that's happening more frequently now. So we see it a lot more since COVID. It's a very inflammatory autoimmune based condition that a lot of younger people are struggling with. And Dr. Smith has kind of thankfully taken this under his wing as a cardiologist and has really helped a lot of people and helped me help a lot of my patients. So he grew up in Oklahoma City and joined CardioVascular Health Clinic in 2016. He earned his Doctorate of Medicine at the University of Oklahoma College of Medicine. He completed his residency in internal medicine at the University of Oklahoma Health Science Center, where he served as chief resident. I was also a chief resident, just not there. He remained at the University of Oklahoma to complete fellowship in General and Interventional Cardiology. He specializes in the management and treatment of coronary artery disease, peripheral vascular disease, heart disease, and cardiac imaging. He is a board-certified internal or interventional cardiologist. And I would say that he specializes in POTS. He sees a lot of POTS, you guys. Patients are drawn to him because he's got this quick wit and a great personality. He also gives every patient his cell phone number. I'm not kidding. My dad's his patient. The patients love that. He's way nicer than I am. He's dedicated to helping his patients find non-invasive treatments and lifestyle modifications to live a better quality of life, which is why I resonate with him, and I think you guys will as well. And he serves in central and western Oklahoma with complete cardiac care. So if you're listening in Oklahoma, this is your guy. You should definitely drive to see him. He doesn't have a license in any other state. We talked about that. I'll work on him for you, all my patients out there. But Dr. Marcus Smith, thank you for joining me.
Well, thanks for having me. What an introduction. That's an introduction that my mother would be proud of.
Well, she's an Oklahoma lady, so I'm sure.
Yeah.
So I like to start by you just kind of tell everyone, what is it like a day in the life of Dr. Smith? Like, what do you do? What is your why? What brings you passion? Because, you know, my patients know I say this all the time, being a doctor is not easy. It's probably the most rewarding thing in the world, but it's not easy. So what is your why? What brings you joy? What is it like to follow you around in a day?
Yeah, that's a great question, actually. So, you know, I would say, first off, describing a little bit about kind of who I am in terms of my practice. I came out of fellowship thinking, like most people did, that, hey, I need to work for a big, corporate hospital, and I need to kind of go that route. And I did that for a year, and I said, I don't know. I kind of had an entrepreneurial spirit, and I kind of had this thought of, is there more out there for me that would fit my way of treating patients a little bit differently, a little bit more patient-centric? And so I was really fortunate to land into this opportunity here that I'm currently at. That is it's a rising field of medicine in the private sector called an OBL or an ASC, which is the breakdown of what means an office-based lab or an ambulatory surgery center. It means that a lot of healthcare is provided nowadays on the outpatient basis. And we were figuring to ourselves, if we could get cardiology involved in that, could we get kind of better care, more affordable care to people doing it outpatient? And we just turned 9 years old in August. And I think we've done a really good job of kind of doing that. We've kind of done in Oklahoma, a lot of the stuff that has previously been done in the hospital, we've done in the outpatient world. My day-to-day stuff looks very similar than any other doctor. There's a mixture of procedures, which about 2 days a week, and then there's a mixture of clinic about 3 days a week. But most of it's done outpatient. So other than the setting being different, the acuity of patients for the most part, the patients in general are similar to what you'd see in a hospital setting, just doing it outpatient. For me, kind of what I've discovered now, I'm kind of in my mid 40s, kind of what motivates you. I think originally getting out of the debt hole was a good thing at first, saying, okay, hey, I'm getting to actually make money where I can pay off my debts and do all that. But I think I said this to med student the other day. I said, that quickly fades. I don't think your motivation shouldn't be an economic motivation, because if it is, you probably should go into a different sector of business or something like that. What really truly does, and this may sound very kind of cliche, is helping people has been like the foundation of what motivates me. And I chose cardiology for the acuity of it. I love the fact that, probably 2 weeks ago, I had a guy that was metaflighted to me, 45-year-old guy that had cardiac arrest in front of his family, including his 10-year-old daughter. Metaflighted to me from a small town in Oklahoma. I was able to find and diagnose a blocked artery, open it up with a stent, did it in about 45 minutes through his wrist, and the guy walked out of the hospital in about 48 hours. To me, those kind of stories of instant impact, instant extra years with your family were so meaningful to me that it was worth getting up at 2 o'clock in the morning. It was worth doing those years of training. And I think those are the things that really excite me to be able to do that. And I've been able to do it in my own community. I was born and raised in Oklahoma. I live probably about 3 miles right currently. My practice is about 3 miles from my childhood home. So I'm kind of boring in that regards, but it's really good. It's a good feeling to be able to give care to the citizens of Oklahoma. And that's been really nice for me. So I think those couple of things have really kind of made my day-to-day life pretty easy in that regards, because I really do enjoy what I do.
Yes. I love all of that. I agree with all of it. If you want to make a lot of money, medicine is not for you. You can go do something in business and make a lot more. But that's why I like you. That's why I send all my patients to you, because you do it for the right reason. You do it because you want to help people. You want to make an impact in their life. And then you're good at educating people as well. And, that's why I do it. Honestly, I think that a large majority of chronic disease is because of poor diet and lack of education. It's not because people, I don't think we should blame people. I don't think the only people we should blame are the food industry, and then the people who make all the rules in the medical society, and maybe, school systems. But again, that comes from the government, from the FDA, and it's just lack of education. And that's why I do this. And that's why I invite people on like you on here, because I really think that if people start demanding better education, and then we demand, better food choices, better things, then we won't have as much chronic disease as we currently have.
Yeah. I kind of started saying in my practice, health is an active process, not a passive process. You need, maybe at 20, it's passive. You're, a young person and you don't have to work to be healthy. But I tell the most people that I see that you've got to work to be healthy. You can't be passive. You got to exercise. You got to be compliant with your diet. You got to do these things. And it gets harder as you get farther down that age spectrum. You got to put even more work in to maintain that. And some people don't necessarily look at that way. But when you come to see me, that's one of the first things I preach is, I always say I'm full of sayings, by the way. There's another saying that I use a lot of times that says, because I get a lot of people that sent to me just for the concept of, hey, I've got this family history, so that means I've got to have heart disease because my dad had it at 55. What does that mean for me? And I say, you know what? Genetics loads the gun, but lifestyle pulls the trigger. Mm-hmm. So what that basically means to me is how you live your life is so much more impactful than the genetics you're given in most people. I do think that maintaining a good weight, maintaining a good diet, controlling your diabetes, controlling not being a smoker, those kind of things have far more impact. And those are the things you have control over. So you've got to be an active member in health, and you got to be an active member in the process of achieving your health. You can't just be a passive member in my office. You got to be the most active member of the team. I'm just somebody there to help you along the way, but you've got to take the bull by the horn and look at it like that.
Yes. So for my patients out there, that I tell you all the time, I'm the cheerleader, you're the doer. Well, I can give you the tools and I can cheer you, but I can't make you do it. Right. And, I have a saying too, and I use it for success and for health. So health is not owned, it's rented, and the rent's due every single day. It's the same thing with success. And you laugh, but that has been on my refrigerator in my office since the day I got out of school. Yeah. I've moved that refrigerator multiple times. It's on my refrigerator at my office right now. It's got crappy handwriting and it says "Love Cassie." And I wrote it in 2017 and I read it every day. Success and health is not owned, it's rented, and the rent's due every single day. And it's true. Like if you're going to stay healthy, then you have to make those decisions every single day. Are you going to mess up? Yes. Are you going to have a piece of chocolate cake? Yes. Are you going to skip the gym? Yes. But in general, you have to participate in your health. And the cool
you go.
Yeah, no, I get so fired up. I get, and the cool thing though, the most fascinating thing is that the human body was made perfectly to fix itself. Like we were made to heal ourselves. We were made to function well. If you think about what the human body does just on a daily basis, on a minute basis, like the trillions
Right.
and trillions of interactions that happen just so that you and I can sit here and have this conversation is mind blowing. Right. And
Yeah.
so,
Yeah.
and the thing is, like, you really can heal your body if you just have the right,
Sure.
education and the right. And so that's where I think that's my passion. I know that you have a lot of passion in that as well. And
Yeah.
so that's kind of why so POTS, postural orthostatic tachycardic syndrome. I never even really heard about this in school. Like, they don't really teach you this. They might have thrown it in when you talk about cardiovascular system for like a hot second, like, oh, there's this disorder where your blood vessels don't work right, but it's not very common. And then they like kick you out the door. Right. So I get out of
Right.
fellowship in 2017. I might have saw a person here or there, but I feel like 2020, it kind of like exploded. And I had all these young people coming to me and they're like, I'm dizzy. I'm dizzy when I stand up. I'm thirsty all the time. My legs are swelling. My blood pressure's low. Nobody knows what's wrong with me. And I'm thinking, well, they're adrenally insufficient, right? No. Their thyroid's off. No. Like, and so then that's where I met you and we were kind of chatting, and I think you even kind of started telling me about this. I start reading about it, but I saw it more and more and more after 2020. And what I think, and I would like your opinion, it's almost like Hashimoto's. It's like an autoimmune process of your body where your blood vessels become inflamed and then everything works backwards. And the more stressed you are and the sicker you are, the worse it gets. And I mean, I've seen people, you've seen them because I've sent them to you. I've seen it. I had a 19-year-old girl that was bedbound in Tulsa, Oklahoma, who hadn't got out of bed for 2 years, like not out of bed because she was so sick. And she wasn't overweight, people. She wasn't obese. She was like 90 pounds, but she couldn't eat. She couldn't stand. She couldn't do anything. And I mean, it's crazy. She walks in my office now. I get so happy when I see her. Like, she comes every 6 months and she's walking and she's gained a little bit of weight, and it makes me so happy. So it's a very awful autoimmune disorder, but I just want your take on, like, why do you think this is happening? What is your take on the anatomy of it? Because that's just me, the little endocrinologist. Why do what's happening? Why is it worse? What are some things people can do?
Yeah, I mean, I think you're right. You hit the nail on the head. I think that is the time frame for what we were seeing here. That I never got told this diagnosis in cardiology fellowship and all the years of training, and it was kind of a self-taught kind of thing. But I did start seeing the same trend. And to your point, whether it was due to the pandemic or whatnot, I think a lot of people were exposed to something that caused them to have some autoimmune issue, right? And if you looked at the propriety of who I see with this diagnosis, it's 15 to 40-year-olds, predominantly women, that usually some people have frank autoimmune issues, like you mentioned, Hashimoto's, Graves' disease, rheumatoid, lupus, whatever. But some of them started after they had some kind of exposure. Now, we blame COVID for that, but I mean, it could be mono, it could be the flu, it could be anything that turns your immune system on. It parlays into being this autoimmune issue that affects what we call your autonomic system. So, I've kind of not used the word POTS as much in the last couple of years because I don't think it's a broad enough term. If you were to look up POTS, it means postural orthostatic tachycardia syndrome, which is basically an inappropriate rise in heart rate when you're subjected to standing up. But if you talk to these patients, they have so much more than that. So I think a better terminology that I kind of use is autonomic dysfunction or dysautonomia, making reference to your autonomic system, which regulates cardiovascular issues, genital urinary issues, gastrointestinal issues. And when you do talk to these patients, you do find that they have so many more issues beyond just, hey, my heart rate and blood pressure are out of whack. And I talk to my patients, and it's not that I think we have all of a sudden a lot more POTS patients. I think we have a lot more ability to understand that POTS exists. I think being that this diagnosis is primarily young to middle-aged, healthy appearing females, that a lot of healthcare providers just put their blinders on and they think, hey, this is stress and anxiety. This girl's just stressed out. And I think it's a very kind of biased, almost sexist thing that's built in to providers just automatically just turning their head off to this. If you walked in at 60-year-old man with the same symptoms, you'd get every test in the book and you'd have people really looking at you. You walk in as an 18-year-old female, nobody pays any attention to you, and you get told that this is stress and anxiety. So I think, the average POTS patient has had symptoms for greater than 2 years and seen greater than 10 doctors before anybody's even landed on this as a diagnosis. And I think that's really sad when it comes to we could do better. Let's put it that way. We could do better as healthcare providers about looking into these people a little bit more. And I think, if you look back at it, a lot of these patients come in with their mothers and they said, this was me when I was 20. I'm 45 or 50 now, and it's not necessarily me, but it is me 20 years ago. And I do think POTS was there 20 years ago. I use the analogy of something like autism. The reported rates of autism in the 70s were like 1 in 10,000. Now it's like 1 in 100. Do we all of a sudden have a bunch of autistic people now that we didn't have previously? No, I think we have better ways of finding out that some of these people in the 70s and 80s were autistic. And I think POTS is definitely one of those weird, yes, I think there's been around for a long, long period of time. We are now finally getting some limelight to what's going on. And I think what's hard about it, it's not an easy diagnosis to make as a provider. I don't have a blood test that I can do, and we'll go over some of the diagnostic workup. But I do think those are some of the hurdles that make it a little bit more of almost like a niche kind of thing where you have to be looking for it to be kind of seeing it even though it's right in front of you.
Do you like what you've heard so far? If so, Modern Endocrine is now able to provide telehealth services in 8 states, including Arizona, Nevada, Oklahoma, Texas, Ohio, Illinois, Michigan, and Georgia. If you would like to become a patient, visit our website at www.modern-endocrine.com/contact. You can also email us at hello@modern-endocrine.com or call our office at 405-286-1571 to schedule an appointment. Please note, we no longer accept insurance for new patients. However, we do have customizable membership programs available. Your first visit will include a detailed intake, and lab orders will be provided to further assist us in developing your 10 stages to ultimate health plan. We do offer discounted lab rates with a nationwide lab service. And now back to the show. Yeah, so I have several points to that. So yes, I do feel like this is like sort of like what women go through when they go through menopause, right? When women go through menopause, a lot of them get put in the crazy category, like, oh, you're anxious, here's your SSRI, goodbye. This is like menopause for young girls, right? So this is just like people don't know what to tell you, and they do just think you're anxious or you're crazy. They put their blinders on, and they, anytime doctors can't figure anything out, it's supratentorial. Right, because we have egos, unfortunately. Any provider has this big ego, and if they can't figure it out, it's all in your head, which is really frustrating. Like, get over yourself, all of you people that are like that. Because so I almost do feel like it's like menopause in younger women. Interestingly enough, though, you also said like the autism thing. So I just actually read a statistic about that autism even in 2000 was like 1 in 250. And then now in places in California, it's like 1 in 50. And so the question is, do we have a better diagnostic way of finding these people? Or is some of it our food, our diet, our lifestyle, inflammation, things like that? But it is very interesting. It's a very sad process. And it's like you said, maybe that is a good point. Maybe it's not POTS. Maybe we should just call it dysautonomia, or, it's an inflammatory, kind of like we do type 3 diabetes, right? Type 3 diabetes is now this, memory issues and inflammation of the brain. Well, maybe this is more of like a dysautonomia from just general inflammation.
Yeah. And I would even piggyback onto that and say that, I kind of look at it like POTS is in the center of this diagnostic world, and there's all these things that are feeding into it. And we're finding more and more about what feeds into it, such as Ehlers-Danlos syndrome, mast cell disorder, pelvic congestion syndrome. And we're finding out if you can take a few steps back and not just look at the POTS symptoms or the autonomic symptoms and say, what's else contributing to this patient's overall health? We're finding out that some of this stuff can be treatable. We treat pelvic congestion in our office. We treat mast cell, and we do all these things that ultimately make the end product of dysautonomia much more manageable. This is definitely almost a onion approach where there's so many layers of this that you have to peel back to get to the core problem. But definitely finding out more and more about this and having more people kind of look into this. Because, if you went to evidence-based literature and say, okay, what's the story on this? There's no evidence-based trials on this. I don't have a societal guideline on this. This is mainly people throughout the country, centers of excellence, one of which I think is us, that have had anecdotal experience, which I know is not the highest level experience. But at this point in the game, you've got to be willing to think outside the box and be empathetic to these people. Because to your point, I had 2 girls from Dallas come see me last week that were in wheelchairs, that were 18, 19-year-old girls that weighed 110, 120 pounds, that, literally are so dizzy, so lightheaded, so fatigued that their quality of life is one of a 70-year-old.
Yeah. No, it's very true. And people are an N of one. That's what I tell my patients too. Like, I might not have a study with 10,000 people that show anything, but it really doesn't matter, because if what you've tried before isn't working, then we've got to try something different.
You have to think outside the box, and you can't be so paralyzed by, evidence-based medicine being the only source of information that you rely on.
Right. And I know you've treated a lot of these people, and, but getting there, like you said, don't look at the tree, look at the forest. I do that a lot with these people, that, like, we kind of send people back and forth, but like a lot of them have hormone issues. Some of them have mast cell, some of it's their gut. They're just completely inflamed. Like, we got to talk about, what the hell are you eating? Are you sleeping at all? How many Red Bulls are you drinking a day, for God's sakes? Like, just things like that, and then some of them, because if you look at the literature, to your point, it's like, well, give them salt. Give them salt, give them albumin, give them salt. Well, that doesn't make some people feel well. Some people it helps. But some of them, I had a patient that, you were doing everything the literature said, salt, midodrine, all these things. She's like, it's making me worse, And so you have to be able to take a step back and figure out what is going on. So
and that's what we kind of approach. I'll say that to you, having a cardiologist, but having somebody like in my practice, interventional radiologist, having an endocrinologist, having an allergist, having, a nutritionist, having a physical therapist, there's autonomic training. It is definitely, in an ideal world, a multidiscipline approach to treating these people, not one stop.
For sure. So in the people that come to see me, I'm like, okay, you need to go see Dr. Marcus Smith for cardiology. I send him to Dr. Laura Chong if I feel like there's any mast cell stuff. She's amazing. She does a lot of mast cell stuff with me. She'll figure out if they truly have mast cell. And so, there's a lot of people involved. Sometimes they need rheumatology, but really I find the main thing is mast cell. Like, they need a good allergist, immunologist, Dr. Chong. They need you to make sure their vascular stuff is good. We're not missing anything. And then they need their inflammation calm down, and that's what we focus on at Modern Endocrine. We try to get their gut right. We try to get their thyroid right. We try to get their hormones right. We try to get their lifestyle right, their stress. And then we make sure we're not missing anything too, right? Like, we always look at their cortisol, and we look at their adrenal hormones. And so but it is, it's interesting. Like you said, it's a spectrum. It's not just like one thing. And there's a lot of people struggling with it. So we've kind of mentioned it, but give me a list of, if somebody's listening now and they're all intrigued, oh, maybe we'll have this. What are the top, 10 symptoms, knowing that everyone can present differently? I mean, lightheadedness, dizziness.
Yeah, I definitely say from a cardiac symptoms perspective first. I would say I always usually ask the constellation of symptoms of dizziness, palpitations, brain fog, fatigue, chest pain, shortness of breath, passing out, nearly passing out. And usually out of those 6 or 7, most people are positive on 4 or 5 of those. Then I usually want to have some context to, do these symptoms worsen when exposed to certain triggers, whether that is a trigger of heat exposure, whether that's a trigger of prolonged standing. And a lot of times people will say yes to that. And they say, well, what's the story with that? What we're finding out is part of the dysautonomia is a dysregulation of your blood pressure and heart rate when you're exposed to those environments. So I always use an example of that. If I didn't have dysautonomia and I stood in a hot shower, one of the first physiological responses that when heat hits my body, I would dilate my blood vessels, which means make them larger, to bring the blood to the surface to cool me off. I'd have about a 5 or 10 point drop in my blood pressure, and I'd have a 5 or 10 point rise in my heart rate, a compensatory rise. But that's such a small margin of change that my autonomic system's working correctly, and I don't notice that. Life goes on. But if you've got dysautonomia and you get exposed to those environments, heat, standing, dehydration, you dilate your blood vessels in the same manner that I do, but now you have dysautonomia. Now you have a 40, 50, 60 point drop in your blood pressure, and you have a 30, 40, 50 point rise in your heart rate. So now your blood pressure is 70/40 and your heart rate's 140. You're going to be symptomatic with all those things I mentioned. It may last for 30 minutes, an hour. It may resolve when that hemodynamics comes back to normal. But a week later, a day later, an hour later, you may be re-exposed to the same elements. And so it's kind of making sure we can find out what your specific triggers are. But definitely the core problem there is a dysregulation of your blood pressure and heart rate based on the dysautonomia and the ill workings of your autonomic system.
Yeah, I think that's a good explanation, a very good physiologic explanation. What I like to tell patients is it's almost like your blood vessels have been terrified or in a haunted house all the time. So like, you know how if something startles you and you're just like, oh,
Right.
and you jump, you
Yeah.
know, that's made to be there so that you don't get hit by a train, whatever. But you're not supposed to jump every time you move, right? Like you're not supposed to be walking around just freaked out. It's almost like your blood vessels are constantly on this such
Right.
high alert that they're just freaked out with any sort of change in
Right.
pressure, in standing, in heat, and your body just can't tolerate that, right?
Yeah.
And so that's the problem. And then obviously, yes, you're going to feel terrible. It's going to spike your cortisol levels. A lot of these people have adrenal issues. And then a lot of them end up very undernourished because when they do eat, their body's not able to, they're very malnourished because they're not absorbing any of their nutrients because their blood vessels they're not going to their stomach. I mean, think about it. When you see a lion and you're about to run, you have zero blood flow to your stomach, right? You're not hungry. Your blood's not going to go there. It's not going to try to get nutrients. And so they just have a lot of other issues involved as well. So yes, that's a good, with the symptoms, I think that's a great, and with people that have, I wear my Oura ring, people that do all this tracking, if you notice, oh my gosh, my heart rate is 140 and I'm super dizzy, that's not normal. And usually a doctor should say that's not normal. We should we should put a heart monitor on you. We should figure it out. But especially if you have that compensatory, like fall in blood pressure and it's a long time. So those are the symptoms that people are going to have, and they're probably going to go to their doctor, and maybe their doctor is going to do a heart monitor, and then they say everything's fine, and then they might do some routine blood work and everything's fine, and then they're not fine. Obviously, they continue to have this. And then I would say the next thing that probably happens is they get put on anxiety medicine, right? Like, oh, well, you must be anxious, or they just get written off. And so then unfortunately they end up, not feeling well, and somehow they make their way to you or to me. Then what? So let's say somebody has the things that you figured out. Yeah, you probably have some dysautonomia. What are you looking for as far as blood tests? What are you looking for as far as like a workup?
Yeah. I mean, to your point there, I think a lot of times if you're looking for this with the right scope on, a lot of times, like we learn from our training, that you can deduce a lot from a good history. And, a lot of times the history is very telling when you ask the right questions. Objectively, as you mentioned, I usually think of a diagnostic test from a cardiac perspective in three forms. You mentioned a couple. You get an echocardiogram, which is an ultrasound of the heart, just to make sure the structure and function of the heart is normal. But mind you, autonomic patients don't have mechanical issues, don't have structural issues, they have physiological issues. So I'd expect the ultrasound to look very, very normal. Because there's variations in heart rate, you do want to make sure you're not missing something called a cardiac arrhythmia, which young, healthy people can get cardiac arrhythmias, which are intrinsic heart rate issues due to electrical problems with the heart. Usually a monitor is really helpful in kind of deducing that. And again, in true POTS or autonomic patients, you'll see elevation of the heart rate, but you won't see it beating irregularly in an arrhythmia manner. So those two things are usually pretty normal in most of the autonomic patients. The third test is the test that everybody comes in kind of a little bit petrified off because I've heard about it. It's called a tilt table test. And I say, no, it's not some carnival ride where we spin you up and down like that. But in their minds, that's kind of what it is. It's actually a really pretty smart test. It is testing for that shower scenario, that heat scenario that I mentioned earlier. It is going to lay a patient flat to take their blood pressure and heart rate. And then we'll sit a patient up to take their blood pressure and heart rate. And people say, I've had that done before, but that's orthostatic changes. The third step is under their tongue or through an IV, give them medicines, either nitroglycerin or isoproterenol, which are forms of blood vessel dilators. So just like the dilation that's occurring on day-to-day basis is through heat and standing, we're going to do it right there on the spot and look for two things. Is there, one, a reproduction of symptoms? And two, is there an inappropriate change in the blood pressure and heart rate? And I'll tell you, most of these patients frankly have, if they've had passing out, they will frankly pass out during the tilt table test. They'll have a radical change in blood pressure and heart rate, and they'll go, doc, that is exactly how I felt 3 weeks ago when I passed out. And I've gotten more hugs after a tilt table test than I've ever gotten putting stents in somebody's heart, because they've actually got an objective validation to what they've been telling people about. Previous to the tilt table test, it's all subjective, right? But this is an objective marker where you say, see, this isn't normal. I just dropped 50 points of my blood pressure and passed out. And so definitely the tilt table test seems like a scary test, but it's probably the test that's going to give us the most cardiovascular objectivity to what is happening with vessel dilation.
Yes. And don't try this at home, people. This is something that you try supervised with a cardiologist. I don't even do it in my office. I'm like, oh, go see Dr. Smith. That way, if your heart stops, he's got you. So this is not something that, not all jokes aside, like, this is serious because yes, I've had my patients tell me that go to you like, yes, I completely, passed out or I, felt awful. And so it is very validating though. And that's the best part. And so then now we have this diagnosis. They're not crazy. So then what do we do? What do you educate people to do?
I always say that part of any treatment strategy from any condition is having a knowledge about it. I think if you're knowledgeable about your own medical issues, you're a lot more compliant. So I try to spend a lot of time educating people about the physiology, about some of the mechanisms involved. Because imagine if you're a 15-year-old girl and you've come to me for the first visit and you said, Doc, I passed out 3 times in the last month, but I don't really know kind of how it happened. It just kind of happened. Well, then how do you prepare for that if you don't even know kind of what happened? But if you can give somebody an explanation for mechanism and trigger, you can really start to allow them to navigate their world a little bit easier, knowing what is their triggers and mechanisms. So first off, I say a good source of education is part of the treatment process. Number 2, I always say, try to solve the riddle with the easiest stuff first. It's not always a dealing of medicines. It's not always a procedure. I'm saying let's try some lifestyle stuff first. And some of the people do really good on this, and some people are already doing it. But I say hydrate, 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 which usually is at least 64 ounces of water a day. Number 2, I say really try to eliminate caffeine and alcohol. And people sometimes say alcohol is easy, but why the caffeine? And they make a good argument. They say, isn't that somewhat of a stimulation? And shouldn't that help me? And yeah, it does stimulate you to some degree, but what it really is an extremely strong diuretic. And if you're trying to build a positive intravascular volume, the last thing you want to give yourself is a diuretic to ruin all the work you've done of hydration throughout the day. Number 3, I say be very diligent when the weather cooperates or when the outfit cooperates sometimes with compression socks, TED hose. We are finding out that lots of people have a tendency over excessively of pooling blood in their legs. And how that physiologically helps you or hinders you is if you're pooling a lot of blood in your legs and you've sat down or stood at a counter for a period of time, you're a student in band, that blood is pooling in your legs. And when you go to move and when you need to have further cardiac output, further increase in your blood pressure, the blood is not in your heart. Your heart hasn't filled up with the blood adequately, and therefore you have a decrease in what we call preload, which translates into an inability to maintain a blood pressure. So we don't want that blood stagnant in your leg. We want that moved back up to the heart. And these compression socks are tighter at the ankle than they are at the calf, and they're bringing that blood out of your legs. The higher you wear them, the more benefit you're going to get. But definitely mobilizing that stagnant blood out of your legs is super helpful. And then I always tell people the 4th thing is be very diligent and very liberal with salt intake. We've kind of vilified salt in America as it's a bad thing. And I wouldn't have this speech with a heart failure, high blood pressure patient, but these patients are the opposite end of the spectrum. And I always use examples of hydration in terms of even like, what is the number one reason somebody dies in a marathon? It's hyponatremia. You're losing salt when you're sweating, and then you're replenishing with water, and you're diluting yourself even further. And the hydration process is further multiplied by a huge multiple when you are taking sodium with your fluids. So I tell people not only have water, but have liquid IVs or water boys or element or take salt pills. I tell people I'd like traditionally most of my patients that are on the not hyperadrenergic spectrum, I say at least 2 to 3 grams of supplemental salt. And if you're on certain conditions like, hey, it's Memorial Weekend, I'm going to the lake, I'm going to be outside all weekend, I have people flex up to 6 grams of supplemental salt throughout a 8 to 6, 7 o'clock p.m. Type of day. So definitely don't be afraid of the sodium aspect in your diet and supplementing it through either sodium chloride pills or, like I said, these products like liquid IV or water boy or those kind of products.
Okay, so lots of comments there. Number 1, did you hear that, America? The cardiologist, Dr. Smith, said that salt is not a villain if you don't have heart failure and you don't have high blood pressure. So I've been saying this forever. Salt is not the problem. It is sugar. Most people that have high blood pressure, it's because you eat too much sugar or too much caffeine. And so I completely agree with the caffeine. And as far as the water standpoint, let's go back to that. You're supposed to drink. So if you're not active, you're supposed to drink at least half your body weight in water. So if you weigh 200 pounds, that's 100 ounces of water. Yeah. If you are active and you are sweating for 30 to 60 minutes a day, you are supposed to drink your body weight in water. Yeah. So if you're a 200-pound person, that's 200 ounces of water. And to your point, there needs to be salt in that, because if you drink 200 ounces of water, you are going to develop hyponatremia without salt. So I love that. So water is very important. The cardiologist said, salt is not the villain. I've been saying this. Not the villain, people. You need salt. You need good salt. I prefer Relight. So liquid IV, some of those have sugar, just so you know. So you want to get you want to get the ones that have just pure salt. So you want to, if you're going to do an electrolyte replacement, look at the ingredients and make sure there's no sugar or sugar additive. You want to make sure it's all salt. So I like Relight. Redmond salt makes Relight, and it is only salt. So it's my favorite electrolyte. I use it all the time. I have tubs of it in my house, and I have packets of it that I travel with. And I typically, I weigh about 125 pounds. I drink 3 to 4 of those a day. I work out for about an hour in the morning, 30 minutes to 45 minutes. I sweat half the time. But I'll drink 3 or 4 of those a day. And I drink, this is 20 ounces. I drink at least 6 of these a day, not negotiable. So 120 ounces of water, at least. I usually drink a little bit of decaf coffee. That's it. I don't hydrate myself with anything else. I used to have a Diet Dr. Pepper addiction, but I got rid of that. And so that's all very good information, is hydration, salt, and salt is important. And I put salt on my food too. I was in Cabo last week, and my friends were making fun of me because I take my little travel Redmond Relight salt shaker because I love my true salt, and I literally keep it in my purse. So anywhere I go, I can salt my food, because it also makes you thirsty, right? Like when you drink more salt, it helps with your water intake. So, and I've never had a blood pressure issue in my life, and I eat all the salt. So to your point, the more you're outside and the more you're sweating, the more salt that you need. So I think those are all very, very intelligent recommendations for people. And then as far as diet, lifestyle, I think stress, we both agree with this. These people have to get their stress under control. They have to get their sleep under control. They have to make sure that they're getting themselves good nutrition, because they have, think about it again, you have less blood flow to your stomach. And so what is flowing to your stomach, you need to make sure you're eating very nutritious foods so that you're nourishing your body, because it's so stressed out anyway, so it can actually fix itself. Yeah.
Yeah, I mean, I definitely emphasize some of that stuff too. I mean, people don't realize the power of sleep, right? Making sure, we think that having bad sleep sometimes is just a part of life. And I'm like, no, actually, that's one of the most important things you could do all day, is make sure you've emphasized the importance on your sleep for any heart or health issue, for that matter.
Yeah, it's a choice. Sometimes it's a hard choice, especially in our career, right? It's like, do I go to bed? Do I finish my notes? Are my patients going to be mad? I've got a million results, but it's a choice. And I think, the more that you've got to choose your health, over other things. And so it is a choice, and sleep is very important. So, absolutely. And then as far as diet, so I want to ask you about this. I get this question all the time, and we can talk about POTS, let's talk about POTS at first. Do you think there's any specific, or dysautonomia? Is there any specific diet that you need to follow?
Information about that out there, to be honest with you. So, I always think I get that question. I don't always have a great answer for dietary. I mean, I kind of give them my general approach to diets in general, but is it specific to, I will say that you mentioned it earlier, part of the dysautonomia that people get is dysautonomia of the gut. And so definitely a lot of these people have gastroparesis. I think that's probably the diagnosis that I think goes undiagnosed, because you go to a GI doctor with GI issues in your 20s that think it's irritable bowel. I've had so many girls come to me. I've had an upper scope. I've had a lower scope. I've had my gallbladder taken out. And guess what? I still have GI issues. And so trying to feed people in the right context of making sure they can deal with gastroparesis and having, quicker transit food and not the slow stuff that stays in your stomach forever. And you see this, obviously you would see this with diabetes, right? I mean, that's where we kind of think of dysautonomia and dysmotility problems in your gut oftentimes is with that population. So I kind of have more of a talk along that manner as it pertains to the gastroparesis that a lot of these people have.
Yeah. And to your point, when you have dysautonomia of the gut, this is why I have learned GI studies and got into stool studies so much, and have spent so much time, all my free time, learning this whole new field of medicine, because I got sick of people coming to me and saying, I'm bloated, I don't feel good, my food's not digesting. And I would do a stool study on these people, and they all have the exact same stool study. They have overgrowth of Pseudomonas, they have overgrowth of Proteus, they have overgrowth of Staph, because their food is sitting there, it's not digesting correctly. And then when it finally gets to their small bowel, their bad bacteria in their small bowel are going crazy. They're overgrowing. They don't have any good bacteria. Then when that happens, you get constipated. So then let me tell you about constipation, people. When your bad bacteria are eating all this in your small bowel and they cause you to be constipated, the way we get rid of toxins is poop and sweat. That's it. If you're not sweating because you can't walk anywhere because you have dysautonomia, and then you can't poop, those toxins are just constantly recirculating in your body. And then you wonder why you don't get any better. Because your bad bacteria in your small bowel are going crazy because the food that you're trying to eat isn't digesting correctly because you're not eating the right type of food, whether it's too much protein or too much carbs. You can tell all of this by a stool study. It's fascinating. Like I was looking at stool studies last night because I had a bunch of them come in over vacation, and I don't even look at the patient's name. I just go through the stool study and I make my analysis. And then I can almost tell you the patient whose stool I looked at before I even get in their chart because I know what's going on. I'm like, oh, this person has diabetes. I know because of this overgrowth. This person, I just know. It's crazy. And then I looked at one. This was the funniest part. I looked at one and I was like, dang, this one's actually pretty good. The only issue is they've got too much Proteus, so they must have a little bit of stress and they're not chewing their food and they've been standing up eating. But everything else looks great. And then I looked, it was mine. And I was like, yep. Perfect. Because I knew, it's interesting. You can tell almost what's going on in somebody's gut. And that's why I've done it. And these people with dysautonomia, it's fascinating because they'll have the same gut pattern. And then once you fix that, then they get better. I mean, your 70% of your GI tract 70% of your immune system is in your GI tract. And so it's impossible to think you can heal yourself when your gut's a wreck, you know?
For sure.
So then answer this for me. People ask this all the time. What is the best diet from a cardiology standpoint? So let's say I have high blood pressure, not heart failure. Heart failure is hard. Let's say I have high blood pressure. Let's say I have high cholesterol. Let's say I'm, typical American. I'm overweight. I have pre-diabetes. I have high blood pressure, high cholesterol. My family had heart disease. Can I eat the carnivore diet?
Yeah. I mean, I kind of go back and forth. The diet stuff is actually, even as somebody with a medical degree, is super hard to sometimes, no pun intended, digest in terms of what is right. Because, sometimes I'll find myself down a research pathway of looking at one diet versus the next, and I can be convinced of it myself. So what I've kind of landed on is a couple of things. In terms of overall cardiac health, I generally try to tell people that eating more plant-based is usually a helpful thing from the reduction of inflammation. We do know that the crux of most health problems do come with inflammation. And so I do find that if you've got horrible coronary disease and you've got some of these really bad atherosclerotic risk factors, I do try to promote somewhat. Now, do I think a full 100% plant-based meal plan is easy for everybody? No, I don't. So, therefore, then you get into this kind of pescatarian kind of, hey, well, maybe 85% of my diet or 85% of it is plant-based. And then I try with my proteins to eat clean, good proteins, not processed. We're not talking about eating sausages or something like that. We're trying to eat grass-fed, high-grade beef, obviously all sorts of really good seafood and things like that. But I will say from a carnivore perspective, if you've come to me and you're 350 pounds and you're super, overweight, and we know that's a huge contributor to your health too. Do I think being on a carnivore diet for the benefits of weight loss is a bad thing? No, I don't necessarily. I think if you incorporate that with intermittent fasting, and I think if you can reduce your insulin levels and really get into fat burning and you get those health benefits of weight loss, I think carnivore, do I think it's a destination diet? Probably not. But I think if it is something that kind of gets you into that mold of weight reduction and the positive health benefits of that, I usually find as long as you can do the carnivore diet kind of in a clean way, like I said, which is kind of the definition of carnivore diet, not necessarily a keto diet when you're eating Alfredo sauce and all these kind of weird things. I think if you're eating a really clean keto diet, I think it could be beneficial.
Mic drop, people. Do you hear that? So this is what I've been saying too. Like he said, if you have hundreds of pounds to lose, your number one risk factor for disease, cancer, and death is your weight. Okay. So I don't give a damn what diet you eat. as long as you're going to lose weight. So if it is a carnivore diet, then get on the carnivore diet. Like, we need you to lose the weight. We need your insulin to go down. We need the inflammation to go down. Is it a say all be all forever? No. Like, but again, there are different types of carnivore diets too, right? And so like, I had Drew Manning on my podcast, you guys, a while back. So, you know, Fit to Fat to Fit. He wrote a book about a clean keto diet. And I read his book. And it was really good. So he keeps the Alfredo out of it. He keeps but it's true. Like, and if you're going to do, and you know, I'm a meat eater. I love meat. But I eat clean meats. I eat grass fed, no antibiotics. I eat a lot of fish. I'm a huge proponent of protein. I think that plants are great, but I think, again, they can't be processed. So the other problem with plant-based is that a lot of this plant-based stuff is processed garbage. Non-beef, all this crap is garbage. Like, if you are vegan and you think you are better because you're eating a bunch of processed garbage, you are wrong. Like, you might as well just go to McDonald's. I mean, so again, plant-based is great if it's fruits and it's vegetables and it's not processed. If you can look at your food and tell me every ingredient that's in your food, I'm probably happy with it. Now, I might not like the ingredients, but you know, that's you know what's good for you and what's not. So that's where I'm like, you and I are on the same page. Like, somebody asked me today, I can't eat eggs. My cholesterol is 180. I'm like, well, your insulin's 56. So let's talk about that. Like, what's killing you first? Probably your insulin, you know? So it's like, if you'll eat eggs instead of cereal, because they're like, well, I eat cereal every morning. And I'm like, the worst breakfast you could possibly have on the planet, cereal and Pop-Tarts, which is what we tell our children, like, this is what we allow food industries to, put on TV so that kids want Pop-Tarts and cereal for breakfast. The worst damn things you could eat. But eggs. So I told this guy, I'm like, eat eggs. And he's like, well, I can't. I have high cholesterol. I 100% will tell you that every cardiologist will tell you to eat eggs before they will cereal. And if not, you need a new cardiologist, primary care doctor, new provider. So I would agree with that. I just wanted you to say it because I say it all the time. And so I think people sometimes are like, she's a little crazy, but you all just heard it. So salt is not bad and the carnivore diet is okay. So great. And then I'm going to make sure that in the show notes, we link Dr. Smith's stuff. So we'll link his clinic. We'll link his, like, how to get a hold of him. If you're somebody who has any of these symptoms or thinks you have POTS, then definitely get a hold of him. His clinic is great. I've had some patients with pelvic congestive syndrome, and one of his partners, I think it's Blake that does it, right? Parsons does. So he'll do embolizations and help you with that. So they have a great clinic. Dr. Smith is very, lifestyle focused, which I like. He's not super medicine happy unless he has to be. And so I'll make sure that we get all this linked. If you're my patient, you probably already see him, that. But I appreciate him coming on and just kind of educating us about this. I think it's something that, like we talked about, it's becoming more and more popular, not more popular, more and more diagnosed, more and more understood. More and more people are struggling with it. And I don't know if it's COVID, what caused the inflammation, if it's just that we're listening to people, but I do see it a lot more frequently. And so I appreciate your kind of expert advice on this because I know you see it a lot. I end my podcast with 3 questions always. And so you get the 3 questions. So, and don't overthink it. This is just so people can get snips of health advice. So what is one food that's very beneficial and why? If you had to pick one food that's most beneficial, what would you pick and why?
I'm a big guy on eating the antioxidant effects of, I'm a berry guy, so if I'm going to eat a fruit, I'm going to eat a raspberry, blueberry, strawberry. I'm kind of a berry guy. I think the free radical reduction, the antioxidant effects of berries are phenomenal. And beets, I'm a beet guy. I know that that's an acquired taste, but we've really found that eating beets is one of these, what I consider superfoods. It really increases your intrinsic nitric oxide levels, which really promote, from a cardiovascular standpoint, vasodilation, which is a good thing, making your blood vessels bigger, allowing more blood flow to go through your heart and all these, your brain and everywhere. So if you can kind of make sure that when you do eat fruits, kind of these fruits that are not super high on the glycemic index, that are kind of better for you, in my opinion, at least from a berry standpoint and the beet standpoint, those 2 foods I think right away when I think of superfoods.
Okay. I love berries and I love beets. So I like both of those.
Beets are really
beets are great. I put them in salads. I just cook them. They're actually really good. So if you don't like the taste of beets, let me give you guys a little tip, because I used to not get a tangerine and eat a beet with a tangerine, and it changes the flavor of the beet. And so then it helps.
There you go.
Little tangerine oranges.
Complete
What
knowledge.
is one thing that any patient can do that would improve their health that is free, completely free?
Good question. I mean, I think number one, the most important thing that I see that's kind of one of my just kind of pet peeves is be a steward to your own health. Understand your own health, not to the degree of having a medical degree, but know your health history, know your numbers, know what your cholesterol is, know what your A1C is. Be an active member of your health process. As we talked about earlier, health is an active process, not a passive process. So when you come in, you don't have your list of medicines, you don't have a good history of what you've had done or what your medical conditions are. I already feel like we're 1 foot way behind the 8 ball on that one. So if I can just, wave a magic wand and make sure people are involved in their healthcare and not just waiting for me to give them advice, I think we have better outcomes when you're an active member of your healthcare.
Yes, there are podcasts, there are social media platforms, there is Google. Now, I don't condone all social media or podcast platforms. You need to find someone that knows what they're talking about. And by that, I mean probably somebody who actually practices
Yeah.
medicine and is
Yeah.
talking about what they actually have a board certification in. Although we did talk about how, you don't always get the best education. But I would agree. Like, you have to be a part of your health.
Yeah.
Do not go to a doctor's office and not know what medicine you take. Do not go to a doctor's office and not know what you're allergic to or when the last time you had labs were. Or, I mean, you can, but you're wasting our time and you're wasting your time too. That is not our job. I get so sick of people saying that. Well, that's your job to have that information. That is not my job. My job is to take the information that you bring me, deduce a plan, educate you, and then allow you to do that. But I'm not your mother or your secretary or your wife. I'm your doctor. So I completely agree with you. Like, take some initiative in your healthcare. Yes. Well, amen. Okay. I love that. And the last question is, what is one thing that you wish you would have known about your health 10 years ago that you would have done differently?
Yeah, I mean, I would say that, and I would say this to anybody, 10 years ago, I would have been in my 30s. I would say that you're never too young to care about your health. I think sometimes that people think health is this distant thing on the surface that, oh, I'll worry about my heart health when I'm 50, because that happens to my grandparents, my older parents. It's like, no, health starts at the middle of life happens. So I think that you're never too young to make sure you know about your risk, you make sure you know about your health, and to make your health a priority. So to me, it's just if I would have said to myself earlier, don't wait till something happens, be preventative, be on top of it, do things to promote good health so that you don't have bad health. So just kind of making sure that you're looking at this on your spectrum, even in your 20s. You're never too early to kind of have a kind of internal compass of what's going on in your own health.
I completely agree. That's one of modern endocrine's pillars. Like, we're moving towards these different pillars in health. And today, my last patient made me so happy. I had a patient today who's 32 years old, and it literally said, new patient evaluation for health and wellness management, would like to conceive a baby. And she just said, I heard you on social media. I think I want to have a baby. She doesn't even live in this state. I've seen homeopathic, naturopathic doctors. Nobody's really done a lot of blood work on me. I have some family history of thyroid issues. I have no idea what my numbers look like. I don't know what my insulin is. You talk about all these things. I have no clue. I probably weigh more than I should. I try to eat well. I don't exercise very much. I think that I just want you to tell me, what's under the hood before I get pregnant. And to me, that I love that. I'm like, yes, sister, let's go. Like, let's do your labs. Let's get you some education. Let's help you make sure that if you are going to bring a life into this world, that you do it in the healthiest way possible. Because, we know if she's already got insulin resistance, then she's going to pass that on to her children. And we know that if you have a baby and you have insulin resistance or diabetes, their mitochondria, like you said, their genes, their gun is already loaded. And so then if they don't make really good choices, then you're putting that kid at, risk of developing diabetes. So I love it when people do that. Like, I would agree, take some initiative. And I wish I would have done that too, right? We all say this when you're a provider, and this just as well as I did. From the time I got out of high school until I got done with fellowship, the only thing you're thinking about is getting through the next 24 hours, right? Like, it's like a 24-hour, like, can I make it through the next call? Can I make it through the next test? Can I make it through did anybody die last night? And then you wake up and you're like in your 30s and you're like, shit, what happened? But you're not thinking about sleeping. Yeah. You're not thinking about eating. All the caffeine, like, oh my gosh, the amount of caffeine I used to drink, like, I don't even know how I was alive. And so
I would say, and you've got me really thinking now, because I would also say I would add to that, don't be afraid as a professional, as a husband, as a wife, as a father, as a mother, to make health a priority. I think we can find all the excuses in the world not to exercise or eat right, because those excuses are right there in front of you. We're all busy. We all have kids that got stuff going on, or spouses that got some. Don't feel bad to take that hour out to do what's good for you. Take that hour out to work out. Take that hour out to do whatever you need. Sometimes people think that their health is just not a priority. Make it a priority. Make that a priority.
Yeah, because you can't be a good dad or a good husband or a good doctor or a good anything if you're not healthy. And I say this all the time, like, it doesn't matter how much money you make. It doesn't matter what you do. You are not going to do it at 100% unless you are healthy. You will not. Like, you say what you want. If you're not sleeping well, if your numbers aren't right, if your weight's not right, you are not going to be able to give it 100%. And then that's not fair to the people you're serving, to the people who are your family members, to your children. And so, yes, you have to be a little bit selfish at first, and so I would completely agree. And I wish I would have, like I said, I feel like I woke up in 2017 and I was like, what happened to my life? And then I just went right to work. And then about 2 years later, I was like, I feel like complete shit. Like, like this is not normal. Like 30, I don't know how old I was, 33-year-old shouldn't feel like this, you know? And then I started going to doctors and people were like, oh, you're fine. You're skinny. You're fine. And so it took me really like figuring out, going down this functional medicine pathway and doing all these things to myself to really, and I will tell you that for once in my life, like I feel pretty, like the older I get, the better I feel like I'm like a bottle of red wine. Like the older I get, the better I feel, like it's great, but I'm also selfish. Like I am, like you can ask my husband, he knows from 5 o'clock in the morning till 6:30 is my time. You don't talk to me. You don't ask me to do things. You don't this is my time. If you need something, you better be dying.
Yeah. I love it. I think that's great. That's a great credo. Yeah, that's great.
Yeah. Well, thank you so much for being on the podcast. I think that people will find this very educational. I might need you to come back on at another point. Now I'm thinking of some other things we could talk about. I would love to pick your brain about hormones and heart at some point, because I think that, there's a lot of miscommunication with some of that.
That's a good word.
There's a lot of miscommunication between heart disease and hormones, and if you do it correctly. And so we might have you come back on and chat with us, but I appreciate your time. And then make sure that you join us next week if you enjoyed this. Our episodes are coming out on Sunday now. I think you guys all know that. So look for us on Sunday. If you liked the episode, make sure that you subscribe. Please leave us reviews, share it. And then Modern Endocrine now has a license in 10 states. So we added Tennessee and we added Pennsylvania yesterday. So now we're in 10 states. So follow us on social media. And if you want to get scheduled, we have a link there. Have a good day. The information presented, including any materials discussed, referenced, or linked within this podcast, are for general educational purposes only, not the practice of medicine. No doctor-patient relationship is formed from you listening to this podcast or utilizing any of the information provided. I am a doctor, but I am not talking to you as your doctor. The information provided is not intended to diagnose or treat health problems, or take the place of the professional medical care provided by your doctor. If you are experiencing any health problems, including problems you believe have been touched upon in any respect within this podcast, you should consult your doctor about the problems without delay. You may ask your doctor whether he or she believes the information I have provided would be helpful to you, but you should still consult your doctor immediately and follow his or her medical advice as your treating physician. I'm just here to provide you basic knowledge about the issues we discuss so you are more aware of them and can better discuss them with your doctor. That's why we call it Back to the Basics. Join me on the next episode as we continue our journey.